Thank you very much. We are starting the National Symposium on Childhood Myopia. I have, of course, with me, I have with me the chairperson, Dr. Shubhangi Bhave. Dr. Kamaljeet Singh could not come. He had to take an early flight. Dr. Praveen, the convener, and I am Dr. Rohit Saxena. And welcome to the very important symposium on a very burning topic on childhood myopia. We will start now with the first talk. It's by Dr. Praveen Vishisht on screening for refractive errors and childhood myopia. So we start with the most important thing of identifying children with refractive errors. Dr. Praveen Vishisht, he is the head of community ophthalmology at RP Center, AIIMS, New Delhi, with a great experience in screening and identifying and doing surveys to identify refractive errors among school children. And it would be great to learn from his experience.
Thank you, Dr. Rohit. In fact, this is such an important session in our country because refractive error and myopia is the second leading cause of visual impairment globally. And if you take younger children, 5 to 15 years of age group, it is the most common cause. In fact, it is responsible for nearly 90% of visual impairment in younger population. Myopia is considered an epidemic now. In fact, this is a report by World Report on Vision by WHO in 2019. It is so surprising that it is expected that by the year 2050, nearly 50% of the global population, 50% of the population will be myopic. It's a huge, huge number. If you see in India, currently we have a prevalence of nearly around 8 to 10% as per the previous studies. This is a systematic review analysis done by Professor Rohit Saxena and team. And this is for last 40 years. If we see the last 10-year data, the prevalence of refractive error among school-going age group is nearly 8.5% in urban areas and 6.1% in rural areas. The trends are showing that it is not only urban area, it is a disease which is increasing in rural population also. So, in fact, in 2001 in a study, we estimated that prevalence of refractive error is 7%. In 2013, we estimated it is almost double, it is 13%. And now it is, at this stage after COVID, is coming around 21%. So estimates of WHO that by 2050 it will be nearly 50%. It believes it will be an alarming sign for us. In fact, I would like to mention that WHO has taken is a global initiative for effective refractive error coverage. And we target that effective refractive error coverage in all age group, including children, should increase by 40% by the year 2030. But unfortunately, we have done even a national survey on blindness, and we don't have the data about effective refractive error coverage in our country. So it is important that we should conduct such survey, and I'm happy to share that now Ministry is planning to start this survey. So within next 2-3 months, this national survey will be started and RP Center will be leading this survey. We understand that you cannot treat myopia by working solely in hospitals. We have to reach to community. It is like iceberg phenomena. Nearly 90% of people are in community. So we have to reach to community to actually achieve this effective refractive coverage. And for screening, as per the National Program Control of Blindness is concerned, we started way back in 1994. It is a fully centrally sponsored program where school teachers were trained and they were referring children based on a specific cutoff of 6/9 visual acuity of Snellen's chart to the ophthalmic technician. And ophthalmic technician, after refraction, the spectacles are being provided totally free of cost. So this is a low-cost program, non-invasive program. All the criteria of screening are very much matching with the school vision screening program. And in fact, this is the screening card which is being used, 6/9 cutoff for the school teachers. If a child can read 3 out of 4 E's, then child is normal, otherwise child is to be referred to ophthalmic technician. The issue is that what is the actual number required to be screened? We are 140 crore now. And if we assume even a prevalence of around 8%, though it is much higher at this stage, we need to screen 25 crore children every year in our country, 25 crore. And among them, 2 crore children need to be provided spectacles every year. It's a huge number. We don't have manpower, we don't have infrastructure to achieve these targets. If you see the current achievement in the National Program for Control of Blindness, the program has just revised their target from 9 lakh to 15 lakh. That means from 5% of the need to 7.5% of the need is the target which has been taken by the National Program for Control of Blindness. And you can see this picture. Even these targets are being not met. If I take country scenario, even only in Gujarat, 33% of the national targets are being achieved in Gujarat alone. So you can think the rest of the country. In Bihar, it is 0% target is being achieved. This is the status in our country. And what we need is, besides school, we need to use another type of manpower for this vision screening, and probably ASHA workers well suited for this thing. We have done a PhD study how to involve ASHA worker in strengthening primary eye care. And we believe that ASHA worker can use this screening card. If not 6/9, it is better to use 6/12 or 6/18 card, and they can screen the entire population, includes those school-going children, for visual impairment in their respective areas. We have more than 1 million ASHA workers in our country, and one ASHA worker is working for every 1,000 population. Probably this is one area where we can look for screening for refractive error. The third component, important strategy, is having vision centers. Vision centers are primary eye care centers. In 2004, when Vision 2020 India launched in India, they targeted that by the year 2020, we should have 20,000 vision centers in the country. This is one important area where we need to work on. The Government of India is also trying to develop primary eye care facilities in terms of vision centers, and even further below in form of health and wellness centers. So vision centers probably is one important strategy by which we can think of achieving universal eye health coverage, including the screening for myopia or any other type of refractive error. In fact, for presbyopia, I believe the spectacles can directly be provided by ASHA workers. We have used this in RP center. We have 27 vision centers, and you can see in last 10 years, we are able to screen more than 6 lakh people in community-based program and have provided spectacles to nearly 50% among them. For vision center, we need to understand it has to be available at, I think, every primary health center and community health center in the country should be converted into vision centers. And we should look for public-private partnership to achieve this thing. And even the school vision screening program can be integrated with the vision centers, so that all the children who are being screened by the teachers, they can refer to the ophthalmic technicians who is available at the vision centers. In fact, this is one comprehensive integrated methodology by which all of us are working together, whether it is government sector, private sectors, NGO sectors, all together, so that we can achieve the target of nearly 2 crore spectacles every year for the school children, and another 3 crore spectacles every year for the adult population, including presbyopic spectacles. Thank you very much. Thank you.
Yeah, thank you, Dr. Vashish. That was very well spoken about the screening. Now I call upon Dr. Murli Kaushik for another important topic, that is risk factors in childhood progressive myopia.
Grateful to AIOS for inviting me to be a part of this national symposium. What I hope to walk you through is what are the possible factors that we need to consider when you're looking at myopia progressing as a risk. Is it important? Of course it is. Dr. Praveen has showed what the data is from across the world, and the data even from India does not look that great. Why does it matter, or why do we want to slow down progression? We know that when the myopia progresses, there are chances of other ophthalmic complications resulting in these children, as well as we know that we need to intervene early because the strongest progression is noticed in early childhood. So we know that they would stabilize eventually by the time they're about 21 years of age. So unless we act fast and we identify those at risk, then there is a problem. The first question is, are we triggering or are we risking children progressing by giving them appropriate correction? So there is a tendency to undercorrect, and the first risk that we need to remember is not a risk, is actually undercorrecting these children. Undercorrection actually results in educational delays. It can risk bullying or even ostracism in terms of their daily schooling. So unless there is a very, very clear indication, which definitely is not a risk of myopia progression, you should not use undercorrection as your first strategy. So that's again very, very important. However, the risk of progression starts off from the way our clinics are designed. So a lot of us, because of constraints of space, may be working in refraction lanes that are shorter than 10 feet. And there you need to remember that the charts today, the digital charts, can be modified or calibrated for distance that allows you to measure visual acuity, but that does not take away the possible accommodation that may happen. So first thing I would recommend everyone to do is take an inch tape, measure out the length of your refraction lane. If it is less than 10 feet, it's very simple for you to calculate. Figure out how much you need to undercorrect every refraction that you're doing. That could possibly be one of the risks that is in our control completely to handle it. The next we looked at is, does it matter how high the chart is put? So again, that does not seem to be a risk factor for us to overestimate the myopia in children attending our clinics. So we did not find too much of a difference in terms of the height. Most of us prescribe monovision glasses. The fear again is, are we risking progression by doing that? Should we actually give a bifocal that was tendered? If you look at the video that's playing on top, this is a girl who's been given a bifocal. And what you will notice is as she keeps reading, she doesn't look through the lower part, but actually lifts up the book to see from the upper part. So the little picture on the side shows what magnification you would see with the near ad. So don't worry, you're not risking progression or you're not causing progression by giving a simple monovision glass, because children invariably will not look through the plus segment, because for them there is no improvement that they see or no benefit that they see. The next part of it is, where do we live? That seems to be a big factor in terms of myopia progression rates. So studies from across the world, unfortunately, the more eastward you go, the rate of progression seems to be much higher. Surprisingly, we're seeing these trends catch up even in the Western world, so to speak. But in the Western world, where there's a mixed population, again, ethnicity seems to play a role. We as Asians living in the East seem to be facing a double whammy of where we are located. So ethnicity plays a key role in terms of in terms of being a risk for progression. The Chinese population in Australia have been shown to have a lower rate of progression compared to the Chinese population living in Singapore. So there seems to be a play of nature as well as nurture in terms of what happens. Again, a recent article that was published in China. Again, we don't have data like Dr. Praveen mentioned in India. We don't know what the difference in progression is in various ethnic groups in India itself. In China itself, they've shown that the progression rates have a difference of almost 20% between various ethnicities in one small district of China. So it's left to our imagination as to what it could be. Some risks are gender dependent too. Again, there is a study by SAW that said that it didn't matter in Singapore, but a majority of studies from, again, across the world have shown that women or female children seem to have a faster rate of progression compared to men. So we do anecdotally see this within India too, but again, there is not enough data possibly collated from across the country for us to arrive at those conclusions. Again, sticking to genetics, these are again things not under our control. The gender you're born into is not under your control. Parental refraction has again been reported to be related to myopia. The odds increase if both parents are myopic, and odds increase with the level of myopia among these parents also having it. This again makes it very, very important for us to get into the family history and find out, because a large number of young parents will walk into our clinic without glasses because they've possibly had a refractive surgical correction. So it's important to find out whether they've ever worn glasses in the past or whether they've even had an eye test. I've had surprises where parents are -2, -3 myopic and just carried on with their life. They don't seem to, it never mattered to them to get their eyes tested. So again, this is a small data set from our own population where we looked at about 100 children. And in those who were rapidly progressing, we found the parental myopia incidence to be much, much higher in them. So again, in children who are progressing higher, or you know that if both the parents are myopic and you put the child on glasses when they're much younger, the possibility of them progressing becomes high, and we need to see how closely we can follow them up. Now that we've done with the nature part, let's look at other factors that are under control. Educational level has been shown again across the world in terms of being a risk for progression. The possible mechanism is accommodation, the way they hold it, and the lack of aberrations that seems to play a role in those who are reading longer hours. Exposure to schooling rather than the age, again, has been shown to be a risk factor. Peculiar cram schools, we do see them across our country too, where children spend very long hours at the school, very little time outdoors. These have been shown to have a very high risk, and there is almost a phenomenally higher chance that these children may be myopic. Again, we are not clear whether it is because of the children spending more time reading or less time outdoors. What that interplay is, that nobody seems to know. But what we do know is higher light intensities and variations between indoor and outdoor time. The more time children spend outdoors, and some countries have even brought in rules to mandate that children should spend time outdoors, that seems to again play a role. Outdoor time, 40 to 80 minutes, reduces onset of childhood myopia. So inversely, children who are more indoors seem to be having a higher risk of progression. So if a child is an introvert, if they've been bullied, it's very unlikely that they're going to spend time outdoors. So it's good to talk to them, find out whether they have friends, what their daily hobbies are, how we can encourage them to spend more time outdoors. Seasonal variation, again, has been shown in North American school children. Mechanism is possibly thought to be due to the lower exposure of natural daytime in winters. But again, fortunately for us in our country, we are blessed with good sunlight pretty much through the year, except for small pockets. So this may not matter so much in the Indian scenario. Does the room light cause a risk? Again, there is data among animal studies to say that brighter the light intensity, lower the kind of risk of progression. So children who read in low light situations possibly again are at a higher risk of progression. And indoor lighting, we know, is almost about 1/10 of what the outdoor lighting typically is. There again have been theories about using light, red and blue, green light, to slow it down. So we again looked at it saying that does it even matter? We did not find too much of a difference in terms of the binocular vision parameters, but the accommodative facility seemed to improve with red and green light. So they were able to read better, but we didn't find any obvious risk that is there. Even with the amount of brightness of light, again, there are studies that show that it matters. Our traditional Gurukul system, where we were outdoors and bright light, possibly made sense. COVID was a big risk. Again, it is attributed to children possibly spending more time indoors than the use of digital devices. Again, we have our own data to show that children who spend more than 2 hours and were on low-dose atropine had a much slower rate of progression compared to others. So we need to see how that can be added on. One other risk factor that we are getting seen reported from across the world is the level of vitamin D3. So this again seems to play a role in multiple forms in causing the myopia to progress faster, and it is again important for us to recommend screening for vitamin D3 in children once in 6 months, and if it is low, to correct it to slow down the rate of progression. One tool we love to blame are digital devices. Again, we feel that children more than 3 hours are at a higher risk. This could be because of accommodative demand. The blue light from these devices has been blamed. The dim lighting from the dilated pupil has been blamed. And then if the children are happy indoors, they're unlikely to spend time outdoors. So this has been taught to see. We looked at changing the brightness of the screen, and we found that the dimmer the screen, children tend to keep their screens at a dim light because they can hold it much closer and the battery lasts longer. But the minute you increase the brightness, they seem to pull it away. Again, parents walk into our clinic saying, my child lies down and reads. That's why the progression has happened. So we looked at saying that's posture attribute to be a risk. So we built a VR-based solution where you can simulate a kind of a reading chart, and we looked at accommodation and convergence in various postures that the image shows. And to our surprise, we found both the NPA and NPC not change irrespective of position. So obviously, posture is not a risk for myopia progression, but the distance that the child holds a book when they're lying down is possibly a risk. This is the last slide where, again, there's this very strong correlation noted with parental myopia, education, a moderate correlation with near work. That again is a very strong relationship or an inverse relationship. If children don't spend time outdoors, the risk of myopia is very high. Light exposure is moderate. Environment has been shown to be very weak. And digital screen, again, has been shown to be very weak. So I hope that this kind of gets you thinking as to what risks are there in the children who come into our clinic.
Wonderful, wonderful. Very nicely talked about the risk factors by Dr. Kaushik. I would now like to invite Dr. Vivekanand from LVP Bhubaneswar to speak on pharmacological treatment of myopia.
So, very good morning to everyone. So basically, I am going to take you through, the pharmacological treatment aspect of myopia. So I do not have any financial disclosure for the slides or the content which I am going to share today. So when we talk about the myopia progression and its treatment, many times we are jumbled with like, okay, I know the things, but sometimes we get confused. All I know is that I do not know anything. Probably when I read a lot of literature coming from different part of the world, and then we get confused. But how do I know this? Okay, so if we see, there are things in place now. What is the definition of myopia, pre-myopia, early myopia? So the literature is very much, and then we have varieties of different consensus guidelines. But then why we are so much worried about the myopia and its progression? If you look at the Global Health Initiative by WHO, the common consensus statement, almost 50% of the children would be myopic by 2050. So that is how we need to be extremely aggressive in treating the myopia progression. So what does we have for the use and efficacy of atropine in myopia progression? I think we have a very landmark studies like ATOM-1, ATOM-2, or recently the LAMP study, which is coming up, and probably we'll have those treatment modalities in our hand in India. And this study population, the only drawback of these studies are their population is East Asian ethnicity. So what about our own population? So yes, we do have a couple of studies and a very good evidence that comes from Saxena et al., Kothari, Agarwal, and Kesarwani. If you see, these are the papers which gives us probably yes, the atropine do work in Indian children's. So this is the consensus guidelines which talks about what does not work, what had the minimal effect, and what appears to work. So what appears to work is the environmental modification, optical treatment, and the pharmacological treatment, which I am going to cover today, the pharmacological treatment. So what is this low dose atropine? So this is the most commonly used method of the myopia control. Large studies, multi-center trials, they have shown that it is effective. And what is the mechanism? Probably stimulating the extracellular matrix by scleral fibroblast, and thus arresting the axial length. So commercially available drop 0.01% found to be effective even in Indian children's. And how does it work? So basically there are three possible mechanisms. One is the release of dopamine in extracellular matrix and vitreous that inhibits the retinal signaling process and thus the axial length. Then release of ECM by scleral fibroblast, and how does it affect the choroidal perfusion and choroidal thickening. So once we understand this, I think at the same time we need to be aware that atropine is not act through accommodative the changes, and it also does not work on the muscarinic receptor as such. So what we learn from ATOM-1 and ATOM-2, I think they are the concentration dependent. 1% what ATOM-1 showed us the light, 77% reduction. Highest effect of 1%, but it has its own side effect like blurring of vision, photophobia, and increased ultraviolet exposure. Contrary to that, ATOM-2 came into the picture where it has given us little broad spectrum of understanding what are the concentration dependent effect of the atropine. So 0.5, 0.1, 0.01%, and that's how we are here because of these studies and their outcomes, that what we understand and practice today. So the major limitation of ATOM-2 even is, there was lack of placebo control arm in this particular study. So this is now what currently we are going to understand, the LAMP study where the concentration has increased now from 0.01% to 0.025 and 0.05. So if we understand this, probably this protocol is more or less what we are doing it for, 0.01%. They have divided into 3 arms with 1 more placebo arm, and then followed this patient over a period of 2, 8, and 12 months. So this is the outcome. I think all the eye drops, they have helped to reduce the myopia progression. However, 0.05% seems to be, the most effective concentration. So the conclusion of this study, yes, all drops, they do reduce the myopia. They are pretty safe, well tolerated. However, 0.05% atropine is the best amongst these different concentrations. So do we still have few unanswered questions? Yes, we do have. So like whether the efficacy of both these concentration is going to work for a long term, the rebound phenomenon with both these concentration during washout period is also of concern, and then the efficacy of both these concentration on restarting the treatment in case of the rebound phenomenon. So these are still unanswered question. We have to wait for this to get answers. So what questions probably we are able to answer today? They are like, which is the recommended pharmac agent? I think 0.01%. As of now, we are practicing in India, and we are looking forward for 0.05%. Probably it is coming soon. I think Dr. Saxena is already running a trial in the AIMS. What are the indications? Again, age 5 to 14, simple myopia, increase of the myopia more than, so those are guidelines in place. Where it does not work, I think index or pathological myopia, ROP or the lasered ROP children's. How long to continue for the treatment? As of now, at least for 2 years. How much should we should follow them over a period of every 6 months. When to stop the therapy? Age more than 14 years, or no progression for 2 years when you have treated the patient consecutively. When not to stop? If progression has not reduced by more than 50% of initial progression, and then need to continue for a year. How to deal with the non-responders? Either the high concentration, you can double the dose, or add-on therapy in terms of the optical therapy, which Dr. Sandra Ganesh will talk about. So this is an interesting case I am going to presented to me in 2016, April, 12-year-old male child. So age at presentation was 4 years. Mother was high myopic. The moderate loss of vision probably because of ametropic amblyopia, very high myopia, 28.8 and 28.13 axial length. So if you see the anterior segment, posterior segment, all parameters were normal. Then in 2019, I started this on the atropine 0.01% and followed this patient serially. So in amblyopia clinic recently, we did the detailed workup where what is the sleep hours, what is the near work activity, what is the peripheral hyperopic refractive error, then how much is the outdoor timing. So we start to understand in myopia clinic in detail what's going on with that particular child, and this is what the followed up over a period of time. So 2019 I put them on 1 dose, and still it is going on. Still there is a progression of myopia, possibly because of the COVID time. We don't know, COVID might be the trigger. And then I had to put them on 2 times dose, and it seems to be last 1 year the patient is stable. So I think shifting to the BD dose is one of the consideration. This is another case. First presentation 2018, 6-year-old mother and father here both are myopic. Okay, so if you follow this patient, you will understand. I started atropine 2018 because early age at onset, presentation very young age, and both parents were myopic. So right away I put them on atropine 0.01%. You follow this patient. Again, it seems there is a jump in the COVID time, and then still progressing despite on BD. So again, we don't know. I mean, even BD dose probably is not sufficient enough to really say that the concentration dependent increased doses would help. Third patient, 18-year-old male, moderate loss. There is a kind of moderate amount of amblyopia with this axial length of 24 millimeter. Again, after 1 year, in April 2022, there was a documented progression. Again, put them on atropine, and then you will find that the atropine is working very well even at delayed age at presentation. So this patient was a 15-year-old. So again, the age we need to understand whether early age it work or whether more than 14 years of age it works. So that's the case scenario. This is another 15-year-old male. The father is low myopic. This case is very interesting. You see the right eye is a high myopia, left eye is a very small amount of myopia. You can see the difference in axial length. So 2022, I started on, obviously I would start the patching along with the atropine drop. And you see that what's happening with this patient, there is a progressive increase in the amount of myopia in an eye which has a less refractive error. Or probably you can call the eye which is being patched. So does patching is the culprit or the other mechanisms where low myopic eye is competing to be like, the high myopic eye, and that there is, the progression of the axial length. So we do not know. So, but not the least can always combine the other optical therapies for non-responders, and probably we have a very good evidence from, the European study where they have looked at the combination of myopia and DIMS glasses, and they are pretty much helpful. They are working together, and probably, that's one of the options. So I want to conclude that the low-dose atropine is a well-proven treatment, relatively cheaper, easy to use, easily available, and almost no side effect. Then can be combined with the DIMS or the other optical treatments in non-responders, which Dr. Sandra Ganesh is going to take forward. Thank you very much.
Thank you, Dr. Vivekanand, for sharing how atropine can be used and how we could probably play around with the dosage to control children who continue to progress despite being on atropine. To take forward from your last slide is Dr. Sandra, who's the Head of Pediatric Ophthalmology at Arvind Eye Hospital in Coimbatore, to talk about the optical management options in myopia.
Thank you very much, chairpersons and Dr. Shubhangi ma'am and Rohit sir for your kind invitation. So I'll be touching upon the optical management options today. I think myopia is a very hot topic, and we've been having almost 3 or 4 sessions on myopia itself, this AIOC, and I do not have any financial interest. So I think the previous speakers have given a very good case as to why myopia should be controlled, because most of the cases it is going to progress into early adulthood. In the common study, they found that 50% stabilizes by the age of 15, only 50%, and 75% by the age of 18. So we should do something to control myopia, otherwise it can lead to vision-threatening complications. So the myopia treatment includes myopia correction by way of single vision glasses or contact lenses, whereas when you come to myopia control, it has various options like orthokeratology, night wear lenses, daytime multifocal contact lenses, specially designed ophthalmic spectacle lenses, pharmaceutical therapy as has already been detailed. But to top it all, definitely in all cases we do need environmental and behavior modifications, without which none of the other interventions will really play a good role. So I'm going to be talking on specially designed ophthalmic spectacle lenses, which is a form of optical treatment. The benefits of spectacles over the other forms is the children are already very adaptable to using spectacles. It is straightforward and less intrusive intervention. And for myopia, full correction is always recommended. But what is wrong with giving the single vision spectacles? The single vision spectacle lenses have been found to provide less than a 14% decrease in myopia progression. So we did a short study on the single vision spectacle lenses in our hospital, where we just took around 100 patients with an average age of 13, and we followed them up for 9 months approximately. And to our surprise, we found that almost 59 to 60% of them needed a change, and with atropine, 26% needed a change. So the question is of whether we should be giving the single vision lenses at all in cases where we find a documented progression. So why is it that the single vision lenses causes a lot of progression in myopia is because it induces a hyperopic defocus in eyes which are already having a hyperopic defocus. It can cause a lot of progression in myopia, whereas all the myopic lenses which are designed to control myopia, they induce a myopic defocus that inhibits eye growth. So these are some of the providers which provide myopia control spectacle lenses. So let us look at some of them. The Zeiss Myovision glasses, which were introduced quite a few years back, is a highly asymmetric spectacle lenses where in the center you have an undisturbed foveal vision, and in the periphery they gave relative plus power to partially compensate for the peripheral hyperopic shift. And there is a Zeiss MyoKids lenses where they have a near addition in cases where you find that there is a near esophoria and there is a lag of accommodation, you can prescribe MyoKids lenses. The latest addition to the Zeiss armamentarium is the MyoCare design, which is cylindrical annular refractive elements, which has the plus addition on the anterior lens surface. So they work by creating a simultaneous competing defocus. So what happens here, as you can see, there is a central clear zone of 7 millimeters in the up to 9 age group and the 9 millimeters in the above 9 age group. The central zone provides for the clear distance vision, and in the mid periphery you are having these areas of zones where you have the cylindrical elements that create the myopic defocus. So there is a single vision and there is intermittent zones that induce the myopic defocus, and by way of this design it creates a like a myopic defocus and reduces the progression of myopia. So they have two platforms, MyoCare S for children younger than 10 years where you have the 7 millimeter central addition, and the MyoCare S which has a 9 millimeter zone for children over 10 years. So the mean surface area in the MyoCare design is plus 4.6 diopters, and in the MyoCare S is around 3.8. So the why it is so? Because younger children have a greater tendency to progress, and in the older age group above 10 years the progression rate is lesser, and also the adaptation is easier with the 9 millimeter zone as compared to 7 millimeter zone. In the above 10-year age group they have more of near vision demands, and also the adaptation to 7 millimeters will be a little less, though in highly progressive cases you can try the MyoCare in older age group also. So the power range is plano to -9 spherical and -6 cylindrical. So these are the clinical trials which are currently going on with the Zeiss MyoCare lenses. As you can see, many of them are in the 1 year or within the 2 year, and many of these studies are in China and few in Europe as well. There are single and multi-center studies. So in coming to our personal experience, we have a 6 months follow-up results with 50 children who were corrected between 0.75 to -6 diopters fitted with the MyoCare spectacle lenses compared to single vision age match group with 63 eyes 9 to 14 year age group. The baseline spherical and axial length was very comparable between the two groups, as you can see, -2.39 versus 2.49. And at 6 months, we did find a slower progression with regard to both the spherical equivalent and the axial length in the MyoCare using children as compared to the children who are using single vision lenses, 0.04 plus minus 0.13 in the MyoCare group versus 0.29 in the single vision using children. And the progression of more than 0.5 diopters was nil in MyoCare versus around 14.8 children with single vision wearing lenses. And similarly, we found an axial length reversal in 24% of children who are using MyoCare versus 5.6 children who are using the single vision glasses, and around 50% of single vision users required a glass change by even 6 months as compared to 10% with the MyoCare lenses. So coming to the next lens, which is the defocus incorporated multiple segments as marketed by the Hoya. The central clear zone here corresponds to the wearer's central refractive power, and the mid periphery you find a honeycomb design, 50 to 50% area between clear vision and the added segments, and this gives a plus uniform addition of 3.5 in the mid peripheral area. So here there are a lot of published studies. They have been around for around 6 years in the international market. In India it's been available for the last 2 years, and a lot of studies have reported good results with the DIMS technology. And there was a poster recently in the 2023 annual meeting which showed a 44% had less than 0.25 annual myopic change with the DIMS glasses, and 22% showed no change or reduction in myopia. Similarly, in Asian children also there have been a couple of studies which show that the changes in spherical equivalent refraction in European children are comparable to that which find in Asian children also when you compare between the DIMS and single vision glasses. And similarly, with regard to axial length, 40% had a less than 0.1 millimeter annual axial length elongation with the DIMS, and 19% showed no elongation or axial length shortening. So this axial length shortening is something that we see across all types of optical platforms, a few in atropine as well, which we don't see that often with the children who are using the single vision glasses. And similarly, as you can see, the axial length changes in Asian children also similarly, like 57% showed between 0 and 0.3 millimeters with the DIMS, whereas only 16% with the single vision, and more than 0.3 millimeters you see around 84% of children on single vision, very less with the DIMS. So DIMS also works well in atropine as shown by my previous speaker. So you can always, it's very amenable to combination therapy as well. In case you find significant progression with glasses or with atropine, you can add the second one as an additional option. And you can see with the graphs where the green one is with the atropine, and the red is atropine with DIMS. You see very good control when you add use a combination therapy. And this is our experience, 205 eyes of 103 patients over a 1-year period, mean age of study population being 10 years, and 57% males, 32% had a family history of myopia, 80% of them were prior single vision users for a minimum of 2 years before we started them on DIMS. And the spherical progression with the DIMS was, with the single vision prior to start of DIMS was minus 1.28 per year, and after the start of DIMS it was minus 0.1. So that you can see that's the same patient there. So, and the axial length also we found a significant reduction in progression, and 16 patients need to have a lens replacement. 31 patients showed axial length regression. So coming to the Hall technology by marketed as Stellest by CILAR, here also we find single vision in the central zone and a myopia control zone, which comprises of 11 rings, 1,021 contiguous aspherical lenslets, creating a volume of defocus in front of the retina and thus preventing the progression of myopia. A lot of RCTs already published on the efficacy of Stellest lenses as well. Here you can see almost 67% reduction in progression of spherical equivalent, and 60% for the axial length, and 60% for the spherical equivalent. And so this is kind of tabulates our experience with the HAL, MyoSmart and MyoCare over a 1-year period. But though the number of lenses are not uniform, a number of patients are not uniform, because this is a clinical study, it is not an RCT. So though it will be much good to compare similar numbers, but the age, gender, family history, single vision glass use, the initial sphere, all are very comparable between all the 3 groups. The initial spherical equivalent was also nearly the same as 3.17 in HAL, 2.89 in MyoSmart and 2.25 with the MyoCare. So at the first review we find, so this is a comparison here. Initially we had minus 3.45 with the HAL. At review 1 it was minus 3.49. Similarly in MyoSmart it was minus 3.32 to minus 3.38. And with MyoCare it is minus 2.45 to minus 2.48. So this is the progression that we noted in 6 months. The review 2 we do not have that many good number of patients. So the progression with regard to spherical equivalent you see is very comparable among the 3 groups, 0.1 in HAL and MyoSmart as compared to 0.05 in MyoCare. And this is the comparison of axial length among the 3 groups. You can see that 24.52 to 24.55 in HAL, MyoSmart 5.4 to 5.9, MyoCare 2.1 to 2.3. So you can see a very small elongation in axial length, but these are all very short follow-ups. We need at least a 2-year follow-up to come to meaningful conclusions. So this is the the progression rate that we had over 6 to 9 months of follow-up in all the 3 groups, 0.07 versus 0.11 versus 0.05. All the 3 are much better than your single vision glasses is what I would like to say. And we also have a lot of other optical management solutions like the day wear or a soft ortho-K lenses, though we do not have personal experience in them. But there are a lot of studies to show that they work as well in patients who want to wear a non-glass solution. So peripheral myopic defocus would definitely slow down the progression of myopia associated with good visual function. Most of the patients adapt very well to these lenses, and we did not have that many adaptation issues. They resolve within a week unless there is a problem with decentration or a wrong refraction. and use of these lenses delayed the myopia progression and axial length. Combination of atropine and these glasses should be considered. In our experience, we did not use peripheral refraction as much, though there are a lot of people who are studying that as well, and that would be also good to see the effect of peripheral refraction and these glasses. Thank you.
Thank you, Sandra, for this nice lecture and summing your experience. Thank you. Now, I would like to invite our last speaker, Dr. Jitendra Jithani. He'll be talking about myopia management guidelines and best practices. Dr. Jitendra.
Thank you so much, sir. Thank you. Thank you, AIS, for giving me the opportunity to speak on myopia management guidelines. I think all the previous 4 speakers have made things pretty easy for me. I just have to talk about summarizing what has already been discussed extensively and very nicely by the previous speakers, be it Dr. Kaushik, who spoke about the risk factors, and Dr. Vivek, who talked about the pharmacological option, and Dr. Sandra, she talked about, so all this has been, all of these things have been discussed. It's very easy to skip this because this is what we want to do. We want to correct and control the myopia. So this is step 1, which I will be borrowing a lot of things from Dr. Murli's presentation. So history is very important. These are the risk factors. Younger the age at which myopia strikes, we should be more cautious because these patients are typically non-responders to the treatment. Typically, they progress faster. If there is a history of parental myopia, sibling myopia, this is very good red flags. We can pick up pre-myopes when you have one kid already there with myopia, you can always pick up the other kid quickly. Ethnicity, we already saw from Dr. Murli's presentation. As we go towards eastern part of the globe, we have more tendency to progress and prematurity. This is different from what we normally see. So we have to see whether there is axial elongation in these prematures or not. So typically this prematurity and myopia is a totally different ballgame from what we are treating at this point of time. Lack of outdoor timing, excessive near-base time, and history of fast progression. These are all the risk factors. This is just to summarize it. He has taken it extensively. So it was a very nice presentation. Then we move on to the part 2 or step 2 of diagnosing and analysis. So the first part, most of us do. We do cycloplegic refraction, which is mandatory. When we typically check a kid with myopia, we should not be over-prescribing them. And baseline keratometry and baseline axial length. These are the key to finding out whether the progression is because of axial growth or because of some other changes going on at the corneal level. Fundus evaluation is a must, and pachymetry. So who is the progressor and who is actually progressing? So all this gamut, all this discussion is on progression. We are not here to reduce the prevalence of myopia. We are here to curb the progression because we know that each diopter increase in myopia ends up into having long-term complications of glaucoma, peripheral myopic degeneration, and many other problems. So myopia progression is defined as a progression of glass power by around 0.5 diopter over a year. In terms of axial length, it is variable. Some people take a cutoff of 0.2 millimeter. In our clinic, this is what we do in our clinic. We take 0.2 millimeter over an year for children above 14 years because typically after 14 years, the growth is not much and it is almost stabilized. So if you still see a growth, that means the kid is progressing, and 0.3 millimeter under the age of 14 years, and there should not be any changes in the ocular biometry. So I have kept a small subgroup of pre-myopes. They are not typically myopes, but they are like very small myopes or really hyperopes or emetropes who may have risk factors or who may be abnormally moving towards myopia. So I would also recommend that if you have kids whom you feel that they are at a risk of myopia, we should do axial length for those patients also. So pre-myopes who are non-progressor, nothing is to be done. Only we have to remove the risk factors. What are the risk factors? Reduce daylight timing and outdoor activities near work. So this is what we have to do for non-progressors. We don't have to jump to the gun. Pre-myopes, if they are progressors, may need some myopia management study. strategies. Most important is environmental modification, behavioral modification. These are key to the success for myopia progression control. If there is a myopic progressor, you can do a peripheral refraction. We have been talking about it since last couple of days, and we have understood that whether there is peripheral refraction or not, you can still go ahead with whatever is your combative strategy. Accommodative lag with MEM method, behavioral modification, and two options. One has been discussed as low concentration atropine, because all pharmacological modification ultimately come down to low concentration atropine, and optical mainly are myopia control glasses. Low concentration atropine, we had a wonderful talk by Dr. Vivek. These are some of the guidelines which we do in our clinic, so that is what I am saying. I consider it as a first line, mainly because of cost, of course. And so what we do is we typically first find out whether it is a myopic progressor or not, and then we start atropine 0.01% once at night, and we follow them up at 1 month, just to see whether they have any problems with that, whether the pupil size is increased or not, whether they have problems in near work or not. So in our work, we found that almost 95 to 96% of kids had absolutely no problem with 0.01%, but you have to keep an eye open, and they may have allergy, because it is at the end of the day a sulfa drug. And then after 3 months, and then again after 6 months, typically we wait for 6 months for any progression. We don't wait for a year. We are a little more aggressive in these terms. So we wait for 6 months. We keep on checking axial lengths. Myopia progression has slowed down. Then we don't increase the concentration, or we don't make it twice a day. But if the progression has not slowed down to even 50% of it, then we may think of increasing the frequency. And then if you have a defined non-responder, you know that this patient is not responding to low concentration atropine, we may jack up the dose. Again, once you increase the dose, you have to call the patient back after 20 days or 1 month to see whether the pupil has dilated or there are any other accommodation related problems. So what to do, follow up after 1 month. This is the list of what we do at the end of 1 month, at the end of 3 months, at the end of 6 months, and then we continue to follow them at 6 months. Peripheral defocus lens, excellent talk by Dr. Sandra. She talked at length about what is MyoSmart and what is Hall, what is Care. DOTS is not available right now in India. It is mainly based on diffusion optics technology, where they change the contrast, but these 3 lenses are available. And peripheral defocus lenses, also we call the patient again after a month. We have seen patients in whom they complain that they are not able to see clearly when they are in open areas or when they are playing. So we do tell them that they can wear single vision lenses, because they are not really at risk when they are actually outdoors. Some patients do find it difficult to have a peripheral visual field, because there is a clear central 9mm zone which accounts for 30-degree field. We did visual field analysis for these children, and we found that in the central 30-degree there were no scotomas. So once they have a good fit, everything is fine. We call them after 6 months, and we follow them up with the same set of investigations that we did at baseline. Now, myopia management guidelines, this is the summary of most of what I have been talking about. And I would still say that behavioral recommendations are at the top of the list. No treatment will work without outdoor activity, without reducing the near work. So that is very, very important, and that is a crux of the whole myopia management guideline. The first part takes care of the history part, and then evaluation, categorization and recommendations on pre-myopes and myopes. And then there is about myopia progression and what we do at first follow-up at 1 month and follow-up every 6 months. So that is regarding the guideline. Thank you so much for the time.
Thank you, Dr. Jitendra, for an excellent talk, giving us an understanding of how we need to approach. Are there any questions? Or yes, please, please. That's nice to see that we are going to have a set of questions.
In your slide, you had written atropine if 0.01% is not working, you will shift the patient to 0.05%. But in previous talk, it was twice a day. So do you try twice a day before shifting to 0.05% atropine?
No, I said twice a day and then 0.05.
Okay, twice.
So we have presented our findings of 0.01 shifting to 0.02 and then shifting to 0.05. So we are aggressive in shifting, but not jacking up the dose.
Although I will wish to add that there is less evidence of BD doses and the efficacy across large areas. So we have clear evidence of the magnitude of effect we are getting at 0.01 OD, and then we are increasingly getting evidence of 0.05 OD. There are a lot of anecdotal experiences that have been mentioned, and many of them work. As I said, I'm not saying that this doesn't work or that doesn't work. You need to try in your patient possibly. The lack of accessibility of 0.05 is a very major challenge, and that is why these alternatives have been tried. I hope that we should be getting 0.05 soon, because a trial has just been completed for regulatory purposes, and hopefully we should get access to 0.05.
Is there any atropine drop which is preservative free? Because in young children, that preservative using for a long time, that may be harmful. I don't know if there is any publication or...
I don't think that...
So preservative free were the ones which were made by Audrey Chia, but
Yeah.
in India they are not available.
So at the moment they haven't, I don't think any company is marketing as preservative-free atropine drops. Obviously the cost will start increasing if they produce in unims and all those. At the moment I don't think there is any, the non-supposedly toxic preservative, but yes, that risk is there because
many
of the
people, many patients, they discontinue coming to the doctor, and they discontinue the medicine. If it is repeatedly used, means not continuous process. Suppose 3 months they have used, again after 6 months or 1 year they have come again, we have used repeated, means irregular use of atropine. Is there any harmful effect?
So we don't even know the harmful effects of regular use of atropine. So we don't know the long-term side effects of regular use of low-dose atropine in growing eyes. So we're not sure. At the moment, the evidence suggests that immediately there is no short-term significant side effects, except some children may have a bit of glare or issues related to a little near vision related issues. But irregular use, there is no evidence at the moment. So they should be progressing. That is the adverse effect of not using treatment, advised treatment. That's all I would suggest.
Regarding pharmacological use, everything has been covered, but gummies which are coming with lutein zeaxanthin, those are useful or not? Gummies are coming.
Gummies?
Gummies have got no role in...
Gummies are vitamins. So they're just for general health of the children and parents' mental health, that they are giving some treatment.
More of marketing strategy from the company.
I'll just add on. So the point where it is discussed that the patients discontinue. So the most common problem which I have seen is that the patients have not been counseled properly. They have been just advised of written, आप इसको डाल लो, इससे आपके बच्चे का myopia या number रुकना शुरू हो जाएगा. So I think we need to give more chair time to the patient, explain them properly कि आपको इसको 2 साल तक डालना है, follow-up के लिए आना है, एकदम से बंद नहीं करना. So that's our role as an ophthalmologist. That's very important. So I see this on an everyday basis that the counseling has not been done properly. Why they don't put then?
So peripheral defocus lenses has come so much up that single vision monofocal lenses without peripheral defocus lenses has got approximately, it seems that it is almost useless.
No. Identify so as I think it was mentioned, treatment of myopia is refractive error correction, whatever modality, whether you're looking at single vision glasses or contact lenses. Currently, the only discussion is about progressive myopia. In them, agreed, if the progression is more than 0.5 diopters a year, single vision glasses will have no effect on that progression, and an alternative treatment should be considered in them. So, progressive myopia treatment we are discussing, not treatment of myopia. Yeah, Vivek, you want to add something?
Yes, so, the baseline you have to correct, the myopia to take care of other aspects like, the amblyopia or ametropia, anisometropic amblyopia. And now what we have understood and learned that, usually we do have a tendency like undercorrecting the myopic glasses. So this undercorrection itself is found to be a risk factor for progression. That is why every child has to undergo, or even every patient, I would say, even 20-year-old patient has to undergo a cycloplegic refraction when we are trying to look at, controlling the progression of myopia. That's very, very important.
Yes.
I would like to ask you that there are a lot of these lenses coming up, these peripheral defocus lenses. Is there any particular indication to use each one of them, or we can choose from the basket? Apart from the MyoKits, which is being used for
Yes.
the accommodation lag, other than that, amongst the others, is there any particular indication?
At the moment, there is no head-to-head comparison on the efficacy. All of them have reported a range of overlapping efficacy, so we don't know. So we don't even know if one is better than the other. And definitely, because all of them work more or less in the same way, I don't think at the moment there is anything to choose. I think it's more to do with your availability, your cost, which the parents can and accept. A couple of things about spectacles I just want to add is that there is, of course, there is again no hours recommended, but generally they say up to 8 hours a day the child should be wearing those glasses. The other thing that we talk about, as it was mentioned, that when they go outdoors, they may not necessarily need to wear these glasses. In fact, I often recommend them not to use these glasses, because if the child is engaged in active sports, then an 18,000 spectacle getting broken because of cricket is very heartbreaking for the parents. So I then advise them that when the child is playing only when he's indulging in active sports, he can wear his single vision glasses. But rest of the time, at least a duration of 8 hours should be there when the child is wearing these spectacles, which are for myopia preventing myopia progression. So these are important things.
And sometimes we see that even with these glasses, there is a little bit of progression happening. So each time, do we need to change the lenses? Because each time 18,000 rupees for the parents at a gap of 6 months is slightly difficult. So is there any range that the child can still be able to see with the older glasses? According to your experience?
So there are two issues in this. One, whether we should correct them appropriately or not. That he already said that you have to give the actual prescription. Second is whether the cost increases because every 6 months they have to change. So these companies have come up with a smart thing in that. They change the glass free of cost if the progression is more than 0.5 diopter. I think 0.5 diopter is what would be normally the change. So you can easily ask them to give a free fit for these glasses. So they would agree to change it free of cost.
Yeah, just one more thing.
Yeah. The most important thing is these are polycarbonate glasses, so they are soft glasses. So the scratch rate is very high. This is apart from what you asked, because the scratches are they are very scratch prone. So that is a very big problem of these glasses.
Yeah, one more thing just to add, this entire way to deal with myopia progression start with a proper documentation. So if you document every aspect, are we dealing with other form of myopia, or as you said, when to add this optical therapy treatment. So we assume that we have found out the cause, why the myopia is progressing. Is it axial or is it peripheral hyperopic defocus? So once that the tendency for axial is more, right away you should start on pharmacological therapy with low dose atropine. And you keep them following every 6 months, doing all the tests, repeat. Do repeat peripheral hyperopic refraction. You find predominantly if hyperopic refraction, you can start with the glasses. And then add on the pharmacological therapy. But what we have found in our population, majority of the time, the axial length is a cause. And then again the facilities available, like peripheral and open field autorefractometers. They are not available everywhere, right? So by convention, by default, we start them on pharmacological therapy, assuming that axial length is the predominant cause. But if you get an opportunity to look at other causes, if you find them, and then still on pharmacological therapy, it's not working, still progressing, you can add another modality.
Yeah, I'll have one practical point which I have experienced regarding your question that which age group we should be advising which type of out of all the 4 companies. So in my practical experience, younger age group between 5 to 8, I had advised DIMS. Yes, the children complained of mild peripheral blurring. They were not comfortable. So what I have shifted to as of now is less than 10 years age group. First, seeing the criteria of their logistics, financial thing involved. I prefer giving Zeiss MyoCare lenses because in that the peripheral blurring is lesser as compared to DIMS glasses where the children are experiencing peripheral blurring more. which the older children are able to adjust better. So this is my own practical experience in maybe 4 or 5 children, which I have seen. So that's what I follow.
Your last question, and then we'll hand over the...
Sir, regarding this pre-myopia, like as you rightly said that in premature kids it's a different ball game, but often we see children being referred after ROP screening, and every 6 monthly they are coming to us, and we see a steady decrease in the hypermetropic refraction. So every 6 monthly, say 0.5 reduction or 0.75 reduction, and the child is around 2 years of age. So like how do you tackle these children, or you like we already counsel them for refraining from digital screen exposure to the outdoor light, but still the myopia, I mean it is going towards the myopic side. So in such cases, what do you do?
So pre-myopia and prematurity are two separate things. Only the word pre is same. I did not mean to confuse anybody by saying that by adding prematurity. My whole purpose of talking about prematurity is that it is a completely different type of mechanism which goes on with prematurity. There's a wonderful article by Sableen and Jasprit Sukhija from PGI Chandigarh. It's a very good article where they have talked about what happens with laser. The axial length actually does not elongate, but the cornea stops flattening. And that is why the myopia keeps on happening, and that is why the plus power keeps on getting, despite axial length not increasing much. So the whole premise of this myopia progression and all this discussion is based on axial elongation.
Yes.
Apart from that, nothing else.
Quick, short.
Yeah. I only want to know about whether you are also seeing a growing tendency for late myopia. I have seen several children who are not children but who are 20-year-olds, and by the they have been regularly refracted, and by the time they are 22 and 24 they come up with myopia. So I'm just very surprised. Most of them have a lot of near work, but any tips and clues?
So progression, we used to earlier see it stop when children were about 14, 15. Post-COVID, we are seeing a small set of children where the progression actually starts from about 17 and goes on till about 21. So now I tell children that they need to come back in for a longer follow-up. And some of them, I've started them on low-dose atropine when they are about 19. And it still seems to work in them.
Thank you.
So thank you, everybody.
Just to add, your question, like I have presented 2 patients, they were beyond 14 years. One of them was 18 years. So we do not know. The COVID is probably the trigger for, these elder children to have the tendency for myopia.
Because my own daughter, she was 20, and after that,
next
year, she got
we never know.
True, right? We are seeing. So the risk factors remain, risk always remains. So thank you, everybody. Thank you very much for coming to this National Symposium on Childhood Myopia, a very pressing problem. We are virtually at the fag end, but I'm all the best for the last session in this hall. Thank you.